amniotic membrane grafting in ocular surface burns and in SJS. I have no financial interest in the matter. So we know that the interest in the human placenta is of the amnion, the chorion not being useful to the ophthalmologist, and the amnion has got basement membrane and stroma, which is about 20 to 50 microns in thickness, and the useful feature is that it is anti-inflammatory and it modulates stromal scarring. So amniotic membrane has got a lot of uses on the ocular surface, including reconstruction of the ocular surface in pterygia, but perhaps the most emerging use is in association with limbal cell transplantation, as in SLET. The most important and game changing use of amniotic membrane, however, is with acute chemical burns of the surface and acute Stevens-Johnson syndrome. So we know that in the grade 4, 5 and 6 of Dua's classification of chemical injuries, amniotic membrane plays an important role. Stevens-Johnson syndrome is a completely different ball game, and the purpose of the video is to show that the surfaces of the skin is denuded and the patient is often on life support system, and doing an amniotic membrane transplantation in the ICU setting is difficult and backbreaking. And in SJS there is denudation of the epithelium, goblet cells and stem cells, both from the palisades of Vogt and the mucocutaneous junction. Gregory's grading shows that severe and extremely severe varieties AM transplantation should be done within 48 hours. The conventional method of doing an amniotic membrane transplantation is to lay the amniotic membrane on the surface, which makes it unsterile, to tuck them inside the fornices and then either put sutures on the lid passing through the fornices or to place a conformer. It is a cumbersome and time consuming and not so sterile process. There are devices like Procera which are available in the United States, and it is basically a polycarbonate ring with a freeze dried lyophilized amniotic membrane attached to it. The difficulty with this is that it covers only 1 to 2 millimeters beyond the limbus. Some people have used an infant feeding tube coiled on itself to tuck into the fornices to hold the amniotic membrane. So we felt that there was an unmet need, and we wanted a device which could be assembled in the iBank and OT and transported as such, or be assembled locally, and it could be stored like a regular amniotic membrane used under topical anesthesia at the bedside in a matter of minutes. So our design considerations went through open loop devices which we thought would conform to the different sized fornices, and finally we settled into 2 ring devices. The sizing of the device is important, as well as the attachment of the amniotic membrane to the device. So this is showing the dry assembly of the device without the AM. There is a notch in the bottom ring and the top ring is placed on it, and it is snap fits. The assembled device is pliable, so it can conform to fornices of different sizes. So this is how the amniotic membrane is attached. It is placed below the the ring is placed below the amniotic membrane, and the top part is clicked into place. So it can be handled easily like a contact lens and in a sterile manner. So I'll be showing you a couple of usages of the amniotic membrane and how this is a pre-assembled device which was assembled under the microscope. Now it is at the bedside, it is being tucked into the fornix. And this is another case of acute Stevens-Johnson syndrome in a 12-year-old child, in which it is assembled on the gloved hand of the assistant and then inserted into the fornix. The thing that I want to highlight over here is that the amniotic membrane, a skirt of amniotic membrane can be brought out over the eyelid to give coverage to the eyelid, which is important in Stevens-Johnson syndrome. You can then fix it with cyanoacrylate glue to the lid skin. So presenting a few results, this is a young child with a Stevens-Johnson syndrome affecting both eyes, and this is the first post-op day and the 14th post-op day. You can see the red arrow shows the presence of the amniotic membrane, and these are the results at 14 days. This is another case of acute Chuna injury in which there was a conjunctival ischemia which was debrided and amniotic membrane placed with the amserter, and you can see the result. This is another case of alkali burns with a late presentation in which surface debridement was done and the amniotic membrane was used. This is a case of thermal burn, and the purpose of this picture is to show that the extent of coverage of the amniotic membrane that it gives to the ocular surface and the fact that it goes into the fornices prevents formation of symlifera. So the advantages of this device is the elliptical design, which conforms to a various shapes of sizes of the orbit. It is deformable. It can be used to AM can be used to drape the lids. We have used bilayers, and you can apply glue on the undersurface and put it in. It reduces the surgical time from 1 hour to 5 minutes. It is fully sterile from assembly to insertion, and it can be assembled, and we have stored it at up to -80 degrees centigrade without any degeneration of the membrane or the device. Till now there have been about 8 usages, and many more usages are coming in now, and we are awaiting long-term post-op data. What remains to be done is to educate the critical care specialists and dermatologists to refer these cases early. Thank you.